Hello, everybody. Welcome. My name is David Miller, and I'm with the National Association of State Mental Health Program Directors, or NASHPD. And we are so excited for this learning community on mobile response and stabilization services. It dovetails so well into what NASHPD's been focusing on the last 2 or 3 years, which is beefing up our nation's crisis system and getting ready for 988 implementation. In the last couple of years, we've been making sure that we don't forget about kids and families and youth. And in that vein, we're very excited to be partnering with the Institute for Innovation and Implementation at the University of Maryland, who's doing this learning community for you all. I'm very excited for this work this next year. I also want to say a big thank you to SAMHSA, the Substance Abuse Mental Health Services Administration, who, through part of the Transformation Transfer Initiative project, is funding this learning community. So a big thank you to SAMHSA, and a big thank you for all of the Children's, Youth, and Family Division members I see on the call today, and of course our incredible TTI projects. You guys are in great hands today. Liz Manley and Shamika Williams are rock stars in the crisis world and the kids in the kids continuum, and looking at what they've been able to build in New Jersey and Oklahoma. You guys are in a great space to be able to take some of those things and replicate them in your states. And we're so excited to look to see what you're going to be doing the next few years as we all move down this road together. I'm now going to turn it to my incredible colleague, Michelle Zabel, who's the director of the Institute at the University of Maryland. Michelle?
Thanks, David. I want to welcome everybody. We are really honored to have been asked by NASHPD to partner with them on the TTI work and to be able to continue our really long-standing relationship on behalf of NASHPD and on behalf of children, youth, young adults, and their families in this country. And so I am Michelle Zabel. I'm an assistant dean at the University of Maryland School of Social Work, and I direct the Institute for Innovation and Implementation. And this work is so near and dear to my heart, as Liz knows. Back when I got to work in New Jersey 100 years ago, and we stood some of this work up to begin with, never did I think in my career we would be at such a crux in our system where we were getting federal support, financing changes, and moving towards the idea of mobile response models across our country to support our families and our communities. And so this is really a monumental moment in time, right? That we all have to roll up our sleeves, get involved in, and begin to work to make sure that how states, how the federal government, how states, and how locales implement this opportunity can really improve outcomes for kids, families, and young adults. And so we're so happy, David said it, to be part of this learning community. And one thing I would say is we started this peer-to-peer work back in 2016 with a number of states. And Liz, if you're going to talk about this more, I'm sorry I'm stealing this from you, but we had 26 states go through it. And so there's quite an element of consensus across this country about what it takes to really run a customized model for kids and families. And we've had the benefit of late to be contracted by SAMHSA to facilitate an expert convening and a number of listening sessions where we were able to work alongside the crisis toolkit that many of you probably already know about, that was put out quite a few years ago by SAMHSA, and really work with experts and community members and representatives across the country to think about what customization looks like. And so this, because we've had an inside view, this actual learning community looks very similar to that document that we hope comes out very soon. And so we're excited to be able to roll this out with you guys. So I'm gonna not steal any more thunder and ask my dear colleague Liz Manley and Shamika to come on and hand it over to them. Thank you all.
Thank you, Michelle.
Yeah, thank you, Michelle. So, and Michelle, you didn't steal my thunder. You set me up nicely for the next part of our conversation. We are very, very excited to join you today to have the first of what we hope is a good year-long conversation about how to bring mobile response and stabilization across this country, which has been one of our goals for a long time, certainly been my goal for a long time. And I think was one of the first things I said to Michelle when we started. So our work together at the Institute. Before I start, my name is Liz Manley, and I work at the Institute for Innovation and Implementation. I'm a senior advisor working on health and behavioral health policy. I'm the former assistant commissioner for New Jersey's Children's System of Care. And before I begin, I just want to say that I had the opportunity to meet Shamika Williams when she came to New Jersey and the peer-to-peer work, and we've been working at this for quite a long time together. So Shamika, do you want to say hello?
Absolutely. Hello, everyone. My name is Shamika Williams. I'm the Director of Children's Services for the Department of Mental Health and Substance Abuse Services. And so, again, in Oklahoma, we have a statewide system in a rural frontier and urban area. So I'm excited to be a part of this presentation with my friend Liz Manley. Thank you.
All right, so let's get started. Let's just, because it's our first in the conversation, someone to contact, and it's the beginning part of the conversation. I just wanted to walk through or sort of lay the groundwork for not only this conversation, but for future conversations. And so one is the learning objectives for today really is to talk about leadership and how important leadership is. Both Shamika and I will, talk about a little bit of our own journeys within this work. And the need to provide leadership in multiple places in order for it to work. And then the key elements of the beginning of someone to contact. And then we're certainly going to talk about 988 and some strategies for 988, which we believe is the beginning part of this conversation for sure. It's not the end point. There's many, many lessons that we all have to learn together on 988 implementation. But as we think about this work, for parents and young people who are trying to access care, this is what it looks like, right? And it's very confusing with lots of different signs, go here, go there, talk to this person. If you get really lucky, then you talk to somebody who knows how to access care initially, and then you get connected to somebody, to get the right services. But the other challenge is not just that you need to know who to call or what number to call. The other challenge in this work is to have both parents and young people ready for particular interventions in particular time. And so part of this work and this journey around mobile response and stabilization, what really is not just to keep young people out of the hospital, which is totally what it's designed to do, but also it's designed to sequence when and how young people are going to get connected to formal support, to make them more effective and make the system work more efficiently in the long term. So part of that means that we have to know when to contact and who to contact, right? And so we need really the ability to contact someone so quickly and easily. This is where 988 is so exciting, right, Shamika? Isn't 988 exciting from this perspective?
It really is, and it speaks to the point that you make. I think parents, when they're in emergency, when parents want help, we want help now. And I think that having a system for psychiatric emergencies where there is help now is extremely important, very much like our medical emergency rooms are.
Yeah, and 988 makes it easy, right?
Absolutely.
But it makes it complicated too, doesn't it?
Absolutely.
So one of the complications that we're worried about, right, that one of the things that we're thinking about is that the customization for children, right? How do you customize how do you customize a crisis system that's going to address the parent sense of urgency is just really important within the context of someone to call,
right?
Contact. And so let's talk about that sense of urgency, right? So what happens for parents and caregivers is they see changes in their children. They hear from teachers that their children are not doing well. Maybe there's a change in their grades or their behavior or their attendance in school. Maybe they can't get out of bed. Maybe they can't get off the sofa. Maybe they're acting out in a way that's more physical. But what parents see is the beginning of change, and they don't know what to do, right? And so if we can get to that idea of parent sense of urgency being addressed with the system sense of urgency, we really can have some great impact, right, Shamika?
Absolutely, and it speaks to that. Parents know, most of us are parents. We know our kids best. And so when some of those signs are starting to arise, again, parents want to get help now, so that sense of urgency is there before it escalates into something greater.
Exactly. And it's sort of the same thing that happens when parents see that their children aren't feeling well, right?
Yes.
They are, they are experiencing some physical symptoms. Maybe they have asthma or diabetes. And so
Absolutely.
the sense of urgency around how do I help? What do I do? Escalates that parent's, anxiety, if you will. But so there's
Right.
energy around what comes next.
Absolutely. And we never want to wait until it gets too late, where our kids gets involved in the juvenile justice system, or even contact with law enforcement, or suspension or expulsion from school. And so again, when those things start to arise and parents start to notice, and oftentimes parents are the very first people to notice that the changes in our kids.
That's right. And there's a lot of things that drive this sense of urgency, right? But certainly when schools are calling and saying, hey, something's going on. I often tell this story about the 6-year-old Savannah whose parent called me really worried and concerned because she had a birthday party. No one came to her birthday party.
Right.
But on top of that, she was pinching kids. She was kind of the bully in the classroom. And then she took a black magic marker to the bathroom and was ready for suspension in first grade. What happened? Mobile response goes in, parents are with them. They actually work through a game plan. We are now 10 years later, and Savannah has not touched back on the children's behavioral health system. She has sought treatment at other times, but always ready and prepared for what that means, and has done incredibly well over that time. Part of what this conversation is about, right, Shamika, when we talk about this, is that we really want to make sure that parents know what to do, because when that parent has that sense of urgency, for many parents, this is the very first touch on a public system. And we want that first touch to be really impactful for them because it impacts the rest of the child's life. Right?
Absolutely. Absolutely. Very much like the little puzzle shape. When those red flags start to pop up, again, that's the perfect opportunity for some type of intervention or intervening to provide the types of support that these families need.
Absolutely. So let's talk about mobile response design, because a lot of folks think of mobile response in similar view of mobile crisis response adult models, right? And we've talked about this before. New Jersey moved away from the word crisis pretty early in its development because the professionals got the word crisis wrong, in the sense that we waited, right, and didn't provide the support to parents in the way that we needed to. So it got confusing for us. And so mobile response and stabilization became what we focused our attention on. And you talk about this all the time, the real purpose of response. You want to talk about that?
Liz, my first experience with this was during a ride along in New Jersey, where we responded to a 13-year-old who was refusing to go to school. I think that upon entering the family's home, what we identified was that it wasn't just the kid was unwilling to go to school, but the kid was experiencing what we would consider a behavior of crisis. There was a lot more depression and anxiety around school, and there are different things that were happening in the school setting. The very thing that was really significant about that is because of that upstream early intervention, the team was able to intervene early in order to prevent the futuristic crisis that could have arisen. And I think that we see that very much in Oklahoma. Our ability to respond early, to connect with kids and families, to begin to figure out what's taking place so that we can, possibly cut off, a more elevated acute situation that has the potential to happen. So that upstream de-escalation, that upstream opportunity to intervene is extremely important in the children's crisis system.
Yeah, exactly. Yeah, I think the idea that we are meeting both young people and parents legitimately where they are, right, is really powerful in our ability to meet their needs much more efficiently and effectively, not just in the short term, but in the long term. So the mobile response design is really customized for children. It's really focused not only on the child, but on the parent too.
Yes. And there's a significant importance with connecting with parents and caregivers around what's happening at that particular time. And so oftentimes, understanding that we're not working with an individual that is alone, but this child comes in the context of a family. And so our ability to connect, to listen to their story, to hear them out, and to provide some support in their decision-making and guidance is extremely important.
Absolutely. And we're not just working on this in the short term, right? I mean,
Absolutely.
the ability to work with parents and actually provide guidance to parents and help parents support parents is really part of that customization specifically for children, because
Right.
we're not going to calm the situation down just for the child, right?
Right.
It's that interconnection between parents and children that's so important. And
Yeah.
caregivers, when we talk about caregivers, we're also talking about children who are in foster care, right? So it's
Absolutely.
not specifically, right?
Yes. And, I think one of the things that I've learned is the fear and the fear is the same as it would be in a medical situation. If you was to hear your kid had a first time medical diagnosis or had some type of injury, that fear as a parent or a caregiver would be overwhelming. And so what we see is the same with parents that don't often understand what's taking place with their kids of the onset of a behavioral health issue or mental health issues. And so that fear for parents is the same. So it's really important to make that connection and get families, parents involved on the front end. A lot of education in some cases.
Yeah, absolutely. And if we go back to that 13-year-old who didn't want to go to school,
Mhm.
right? I can tell you that the work in New Jersey early in those early days, a lot of the work in intensive care coordination and residential care were exactly those young people who refused to go to school and didn't go to school for years, right? Because there were things that were going on. Pediatricians were signing those doctor's notes that said, no, you can't go to school for reasons that they didn't really even understand. And
Right.
so the ability to get there early and figure out what's happening and put that puzzle back together is so important. And the other thing I think is important in there is the real focus on returning immediately, as quickly as possible, to school, to not allowing children to get off track with school.
Yes.
Which compounds the challenges for young people when they miss a lot of school because of their behavioral health.
Absolutely.
So when we talk about someone to contact, right, we're really talking about multiple things, right? So we want to broaden out this idea of not just someone to call, because a lot of young people themselves don't really use phones these days, right? In fact, I saw video. I don't know if you saw this. I saw video of young people trying to figure out how to use a dial phone. They couldn't figure it out, right? Because it was helpful for me to see that, since I often need help from young people to figure out technology. So
Right.
So they don't really call, right? They text, they do all kinds of other things. So we want to think about, in the customization for children, how do we get the most amount of folks to reach out to us? So that call center, right, that place in which that contact is made, operating 24/7, 365 is just really important, right?
Right. And that makes me think about, what you said, our transition age youth, our youth that are between the ages of 16 and 25, they're very much texters. And so really create and they're oftentimes the ones that reach out. And so when they want to reach out, or they see the need to reach out, having multiple options outside of a phone call, having text options and ways that they can video chat and do face-to-face interactions. In addition to that, Liz, I think it's also important to think about, when we talk about, kind of that central call center, kids are all over the place. I know, as a child on the weekends, I stay with my grandparents, and I may stay with my aunts, and they lived in different counties, different places. And so for me for my family, it would be important for them to know there's one central line, one contact, if in fact they got into an emergency or we needed help. And so having a single point of access is extremely important.
Yeah, well, it gets to two really important points that I want to make, right? So one is that when we talk about mobile response and stabilization, we're really talking about a public health approach, right, to children's behavioral health. And that means that the services and supports are available to those who need it at the time they need it, regardless of their ability to pay, whether they're commercially insured, whether they have Medicaid, whether they're uninsured or underinsured. So that's the first part, right? The ability for any parent, caregiver, or young adult themselves to pick up the phone, call for help, text, video chat. All of those things are really important in terms of getting upstream, right? What we don't want is folks who, are getting triaged out, right? The other thing we've learned from parents, right, and caregivers across the country is that if they call, if they pick up the phone, right, make that move to call the public system to ask for help, then they want help, and they want help in their home, in their community. What they don't want is for someone to talk them down over the phone.
Absolutely.
And so this someone to contact is really important to recognize that what we're really talking about is the first point of contact, what to connect the dot to the next thing, which we'll be talking about in the future, right? But
absolutely. And really the important point of really taking the time to help explain to the individual calling, because oftentimes as parents, we don't necessarily know what's going on. And so that engagement process, we're taking the time and with the parent to explain. In addition to that, mental health is not something that in most cases you can physically see. And so again, helping a parent or a caregiver to think through what's happened so that they can help in the decision-making process to the next response and really providing a sense of comfort for that.
That's right. So let's put it back into perspective. So if you think about this, right, you have a parent who's already sort of elevated and worried, right, and some anxiety or energy is around that. So the ability to really think through is beginning to impact that parent or caregiver.
Absolutely.
They're feeling it enough to pick up the phone, call for help, right? They could be texting, contacting, whatever, but they're contacting someone asking for assistance. And our response can't then be, then do this, right? Or do this. Because I don't know about you, Shamika, but I stopped for directions back in the old days before, we had the Waze and all kinds of other GPS things. And I would stop at a gas station and they would say, go up there, you want to go right, you go left, go right. I have to go right away. Like I have to go to the first turn, right, before I forget. Because when you're feeling that anxious, how do you remember all these things? And so for parents to see it takes into account that they're, what they're experiencing, how they hear it over the phone, what that gets translated to. And then when it doesn't work, right? As many things don't work initially with young people. So really working through all of that with a parent, holding their hand and helping them through what's going on with their child is just so incredibly important.
Absolutely. And I think you made a really important point. I'm from Oklahoma, so it would be head to the stop sign, turn down the dirt road, the second interstate. So of course you can imagine what that's like for me. But I think you hit it. The holding your hand is really a real concept. We need people to walk us through these processes, to make that follow-up, to stay connected, to stay on that phone with that handoff, as a part of helping us to get to the next step of help.
Yeah, well, that's, I think, why it's different for adults and children, right? So if you have children who've been through and parents who have seen it before and they understand and they know kind of what to do and they just need to talk it through or have someone to talk through, that's a really different, sort of situation, right?
Absolutely.
Than a parent of a child who's, beginning to demonstrate some of these things. It's sort of like we're gonna tell a parent how to work through, a medical emergency, right? And not send help. Let's just talk you through,
Right.
So we want to treat all of these situations that parents experience in some ways like a cardiac arrest, right? We want to just take them so seriously that we're going to send help and we're going to make sure that young people get what they need at the time they need it. And this someone to contact is just so important.
Absolutely.
So we also just want to talk real quick about this idea of the technology, right? The text, the calls, the chat, the video responses. And I know that this is all new concepts, even for folks who have been at mobile response and stabilization for a long time. And I was wondering where you guys are at in Oklahoma.
Well, we do have a text line and as a part of our response system where we can text back and forth. And we have specialists that have the ability to not just text, but then also have the ability to lead conversations to real-time information that will provide a phone number or a way of contacting the individual for the response. And then we also have our statewide call center who picks up our calls and really walks families through the process, or the individual that's calling through the process before transition into a response. And in some cases, it's about, the emergency may be about a basic need. And so that call center has the ability to help with additional needs if in fact the family needs this. And so I think the technology platform is huge. We also, in the state of Oklahoma, as a part of our response system, we have a lot of iPad technology in place for first responders to use as a part of that. And so we've expanded our platform to really meet the needs of in some cases, anybody that can be, Spanish speaking individuals, as well as individuals who are deaf or hard of hearing.
So I was wondering if you could expand just a little bit. And so folks who haven't heard you talk about the use of the iPads in Oklahoma, that might be really helpful.
Absolutely. Oklahoma being a rural frontier state, we're pretty broad in distance. Our providers they are responsible for county areas, and across those counties, oftentimes it can take anywhere from a few minutes up to an hour for that response. So we've equipped our first responders, primarily our law enforcement providers, with iPad technology. So when in fact our law enforcement is responding to a mental health crisis, as the first responder, that law enforcement officer has the ability to make a real connection with the licensed clinician for the purpose of addressing that issue. And so what we try to do is take law enforcement out of the equation when it's a mental health issue, but oftentimes if they respond first, we utilize that technology. In addition to that, I want to say the greatest thing that we have done here in the state of Oklahoma is in order to reduce the reoccurrence of crisis in individuals that have high crisis utilization, we oftentimes send our parents home with iPads so that those parents can have immediate access to a clinician 24 hours a day, 7 days a week. And so our iPad technology has been huge through COVID. Again, we tapped into different networks that would allow individuals that have FaceTime or video chat in order to come to us through a secure network in order to see a clinician. So our crisis system has heavily relied on a lot of iPad technology, specifically when someone outside of a mental health professional responds to the crisis as the first responder. And so that's been really, really extremely important for us in the state.
It's really been a game changer, right?
Absolutely. Especially during COVID, Liz.
Right?
I mean, that was a huge game changer.
So I think one of the other things we want to talk about is, how important this idea of engagement is, right? Engagement with the young people, but engagement with parents and caregivers. And I was wondering where you're at with the use of peer support within the work. I know it's second generation and even third generation work of mobile response.
Yeah, a lot of times people don't often think of a crisis system having peer support as a part of their crisis system, but for us, it's been one of the most significant. It's been significantly important because when you're going through that crisis as a parent, there's nothing like someone else to really talk you through that has had that experience. And so in our system, our peers are able to do de-escalation with parents and really talk to them about what's going on to get them to a space of calmness. We also have our care coordinators, our wraparound staff, our frontline responders in the state of Oklahoma. They have a lot of experience working with kids who are SED and have a lot of behavioral health crisis. And so they're our frontline responders. And so that technique of de-escalation through our peer support, talking with the parents, helping them to understand what's taking place, what will happen next, and answering as many questions as possible. Our care coordinators are also a part of that diversion as well. Our care coordinators really work to try to get the child and the family diverted away from the crisis, get things a little bit stable. But I think it's also important to know that they have immediate access to a licensed behavioral health professional. And that immediate access can come as an in-person access, or it can actually come as a telehealth access through our iPad technology when in fact assessment has to be made in order to determine the needs for a high level of care. But I think that peer piece is so important.
Right.
Again, our peers have been trained. They know how to talk and communicate, and they're best at engagement. They're the best.
Yes, they are.
They're the
Right.
best. Mhm.
Yeah, it's been such an important part of the expansion and the work of the peer-to-peer work of mobile response and stabilization. Our conversations when we talk to those other states and folks who are trying to bring it up, the role of peer support in this work is incredibly important in terms of engagement, both from the parent perspective and even some of the states that are really beginning to think about how do we engage young people who have who are now young adults who can be part of that peer support work as well.
Absolutely. I've talked to numerous parents across the state of Oklahoma, and one of the things that is really significant and that happens in that peer role, it's not about just following up on the child. How is he doing? If you get a crisis de-escalated, it's not just about following up on the youth. We definitely want to follow up with the young person and the parents about what's taking place and, the continuation of the de-escalation. But it's also important to follow up with the parent on how are you doing? How are things for you? And that peer role is huge in that. Really connecting with the parents just to say, how is your day today? How do you feel about what's taking place? And making sure that they have a person to contact to ask some of those questions that in some cases may be a little embarrassing because mental health, there's still a stigma around mental health. And again, having that personal contact and being able to maintain engagement and keep families connected has really been a huge part of our peers, and they've been leading the way for that.
Absolutely, right? So it's really important part of the work in mobile response and stabilization that we're really thinking about how peer support partners will be part of every part of that process, right? And that the co-responder of a peer support partner and a responder, right, are really important for us to think about. The other thing I think we wanted to just touch on is the use of the assessment tool, right? That part of this work is really about getting a child-specific assessment done right up front so that we understand what's happening for the young person, for the family, so that we're really connecting the right dots, right? And not not both overreacting or underreacting to what's happening for that young person and the parent, right?
Absolutely. And I think also having a valid assessment that really looks at some of those higher acuity things like suicide. State of Oklahoma, we use the CAMS, and it's really been a great tool for us in our state to look at, suicidality and a person's, again, ability for their follow through. And so it kind of guides you through some questions to touch on some of those important things, because we definitely want to keep our families safe.
Yeah, absolutely. And I think that when we think about safety for children, right, we also have to think about what does it mean to err on the side of caution, right? Because we often think that err on the side of caution means if we don't know what to do, the young person should be in an inpatient.
Absolutely.
Right? And I think one of the lessons that we've learned in the 20 years that New Jersey's been at this work anyway, is that err on the side of caution and having a young person enter an inpatient unit actually can be more harmful than if we had done, if we had been able to keep them at home. And so trying to figure out what does that really mean? Where is the risk within the risk assessment, right? So, and some of this work we're going to talk about, certainly in the future, but I just put it out there because I think it for food for thought. Part of the reason we want to do a child-specific assessment that allows us to gather information not only on what's happening for the young person and for the family, but also the strengths of the family and the resources that families bring to bear, right, around helping children, right? So are there other family members? Are there other, friends that can be helpful in keeping this young person safe?
Right. And Liz, that's really important because in most cases, young people are a part of a family, whether it's foster family or it's bio or kinship or however. And I think that not having the parents or the caregivers as a part of that assessment of safety can be harmful, because there are situations where parents can do things, whether we're talking about locking up things, whether we're talking about removing things in the household, whether we're talking about providing supervision and watch over the young people for a time period. They have the ability to leverage some aspects of, I don't know if the word is not control, but oversight that could actually maintain a safety, more so at keeping a young person at a community level of care, more so than an inpatient psychiatric hospitalization. Because we know that there is an importance for inpatient utilization, but we also know that the trauma that it can actually pose on a young person that is going into those types of facilities for the first time, and the separation that it caused between a caregiver and a child.
Yeah, absolutely. And I would argue that when we leave parents out, we communicate to them that they're not capable, right?
Right.
And they are capable, right?
Yes.
Parents are more than capable of not only being partners in this work, but leading what's going to happen, right? They're leading and driving some of what's necessary, and that it is the response teams that are supporting and making sure that parents and families have what they need in order for children to be safe. And so, right, and when we can do
You're
that,
absolutely right about that.
Right, and we connect the dots for both young people, because we're also communicating to young people, right? What are we communicating to young people? Your parent is more than competent in taking
Capable. Yes.
Right? Exactly. And when we arrive with law enforcement, what are we telling young people? We're telling them that not only do the responders not know what to do, neither do parents.
Neither do
So
parents.
we really want to be thoughtful in who we bring into these conversations. So the next thing I think we want to just talk about real quick is that the data collection idea is really important right up from the start. We begin to collect information right from the time that we get contacted, so that we know how we did, right? But we also know where to put resources.
Yes. That data collection has to start when the call comes in. I mean, it's important for that data to be collected at the call center level, or the first point of contact, someone to contact level, but then also to be available to the actual responders, to the people that are actually going into the environment in the home. And so that data is going to be really important to provide a quick lens as to what's taking place, but then also for long-term opportunities to shore up your crisis system, to really fine-tune areas of providing those crisis services and supports.
That's how we get better, is when we know.
That's how we get better.
It's also really important once we make those decisions on the data collection, then we're sharing the data, right? Large information, if you will, about how the system is operating with communities, so that they can shore up how they can be hopeful.
Right. In Oklahoma, we talk about maintaining engagement of parents, as we talked today, and I think it's really important to know what do you need to know? What is it from a parent's perspective that they want you to know as a part of that? And so really having a process that you're inclusive of families that may have had a crisis experience, that, early on in the process, they wish they could have said these things. They wish they could have notified or the providers that are responding. What are things that you need to know prior to or as a part of your response? So really being transparent about that process with your leadership and administrators to make those determinations around what it is that you're collecting and how it can be utilized.
Exactly. So let's talk about children versus adult crisis models, because there's a lot of folks who are listening in today who might say, yeah, we do all of that, right? We really do all of that, but there's really an adult model of care, right? There and a couple of key indicators that we generally talk about is this, first of all, this point of contact, right? At the point of contact, what's different in the children's world versus the adult world is we're shooting for, trying to move towards, right? The idea that 100% of the calls that come in from a parent, caregiver, a young person are going to be responded to with a face-to-face intervention, right? That's
correct.
And that in the care traffic control model that many call centers operate in the adult world anyway, that this idea of 80%, de-escalation over the phone isn't really the target that we're looking for, because of some of the feedback that we've gotten from parents and caregivers over time that says that's not really helpful. And then parents believe, at least many of the parents and caregivers that I've spoken to, and I imagine this is true for you too, that their experience is that when they feel like they called at the wrong time, now they wait, right? Because they feel like they didn't understand what a crisis was, or what the system did, or they get frustrated because they can't get help, right? And so they wait now until children's behaviors, the external stuff, the internal stuff becomes external, and children begin to demonstrate some concerning behavior that requires then a more intensive intervention, right?
Absolutely. And I think that is the difference of a crisis system and a response system.
Right.
Again, that's the major difference. I mean, response system is about responding now to the needs of the parents and the child. A crisis system, in most cases, there are more acute needs that have escalated. And so again, you create a system that has a variation, but that has the ability to respond in both ways now, but then also, looking at some of the things that a parents consider now versus a real true, blown out crisis.
Absolutely. So one of the other things that I think is important is this distinction that crisis is defined by the parent, caregiver, young person themselves, right? Rather than defined by the caller, because the caller could be a school that says,
yes,
I need you to come and de-escalate this child, right, in the school. And then what it does is leave out the parent in that conversation, right? And what that does in this early upstream intervention is alienate parents right from the start, right?
Yes.
At least that's been our experience. And so we want to distinguish that, right?
Yes, and I think that's been in our experience as well. And I think that one of the caveats that COVID brought on, and what I see as the benefit of a response system, is sometimes parents just don't have the resources at that particular time, whether we're talking about the emotional resources, whether we're talking about the support system from other family members. They just don't have the resources to address the crisis at that particular time. And so I think the importance of families and caregivers defining the crisis, because they have an opportunity to say help now versus help later. And so we don't escalate up to a more acute situation.
Well, the other thing that it does, right, it is allows us to get there when parents have more energy, right? Because they haven't had to manage this for so long. And two, bring back other family members or other parts of the support system that may, that may have been alienated because of the child's behavior, or, right? It's not uncommon for us to hear from parents that say, they can't go to a birthday party. Like Samantha couldn't go to her grandparents' birthday party because her behavior was concerning, right? So, and so how do we change that? Well, we can bring grandparents into the conversation, right? Grandparents know what to do when Savannah is stressed, right? So that changes sort of all of these important dynamics. The other, when we talked about the assessment, I just wanted to clarify on the assessment, right? Well, you guys in Oklahoma are doing using the CANS. New Jersey uses the CAT, the Crisis Assessment Tool, which is a part of the CANS suite of tools, right? And no matter what part of the suite of tools that you use, they all include the same, there's a core group of questions that come in that. And the CANS is the Child and Adolescent Needs and Strengths tools for folks who might not be familiar with it.
And just to make a correction, Liz, we use the CAMS. CAMS is the suicidality screening that we use as a part of our assessment. Yes.
Okay. So important to know what tools folks are using, right? And I'm just going to put one other comment in, and that is for folks who are using the CANS, right? They can embed in the CANS a suicide tool like the Columbia as an example, right? So there are ways to think about the assessment process that is very much designed to get to the needs of children and families.
Yes.
And Shamika, maybe you can just talk for a second about when that assessment gets done in Oklahoma. When do you do that assessment?
So as a part of our first responders, our initial response, we really do a crisis assessment. We really look at the situation, assess the crisis, and really try to come up with the factors that are associated with the safety plan as a part of that crisis. Our licensed clinicians will come in and do the, we use parts of the UCLA that we kind of made our own version in here in the state of Oklahoma with the CAMs, with Dr. Jobs, as a part of really looking at the overall assessment for making determinations around, the needs for higher levels of care. Is this crisis situation more on the acute end? Do we need to recommend a acute assessment by one of our psychiatric hospitals? And so we technically utilize our assessments as at the point of contact during that face-to-face. Another point of contact, say for instance, the parents feel like there's a crisis, and again, we talked about them determining, and say the parent says, hey, we can't meet face-to-face until later on this evening at 5 o'clock, versus a 1 hour versus an immediate face-to-face. And sometimes our face-to-face happen within a 24-hour window. We still want to assess, to make a determination around the safety of the child.
Thank you. Hey, listen, Shamika, would you mind if we take a minute and maybe answer some questions? Denise might be able to help.
Absolutely.
Hey, Denise, do you want to join us for a second and share some of your questions?
Can you just
I'll put you on the spot, I think. Sorry. Or do you want me to just take it from
I can do it.
Okay.
Hold on 1 second. We have technical issues because of Michelle. You got it? We're in the same room, so there was some echo. So we have just some clarification about whether or not, Shamika, I believe you're saying CAMs with an M versus CANs with an N. And
that is correct.
CAT is part of the series of the CANs with an N. So that was coming from several.
Okay.
We have a series of questions with regard to peer support and a series of questions regarding the use of iPads.
Okay.
So with peers, this came from Don early on. Can you share your thoughts about using parent peer specialists to assist the family when they become involved with the behavioral health system as a whole?
Mm-hmm.
Sure. And also there was a question about the use of youth peers being included and having difficulty recruiting for those positions.
Okay. So I'll take the first one.
Go ahead, Liz.
Help, and then we'll take the second question. Okay. So I think the role of peer support across your full system, right, is really important. So, the ability of parents to reach out and talk to parents, or young people to reach out and talk to young people is really powerful. So you can embed it in all parts. So through warm lines, through, we've embedded it in New Jersey through family support organizations that are available to answer the phone and warm lines. They talk through things with parents. We often, they do educational opportunities. They get out in the community so that they're available, to parents that we may never meet through the behavioral health system. And then having peer support available through mobile response, through intensive care coordination, and through, the higher intensities of service, like having parent peer support partners who are embedded in emergency departments and in inpatient, as part of inpatient teams, can be really powerful. So wherever you are, I would argue that you want to just add more, right? And wherever you can within the context of your system. And in terms of young people, it's really complicated, right, for young people to be part of the peer support world for a couple of reasons. One is that you need them to be ready and able to do particular things. And we're also encouraging young people to move forward, right, to do other things with their lives if they're interested. So trying to capture young people at the time that they're ready to do some of this work can be challenging, but it's very much worth it. And there are some states that are doing some real interesting work around peer support. So if folks are interested in a little bit of that, we can maybe include it in one of the upcoming sessions.
Absolutely.
Right.
And I would agree with Liz. I want to say this: peer support is the glue that holds the system together. And the reason why I say that, it doesn't matter if you're in a psychiatric inpatient, outpatient behavioral health system, if you're involved in a crisis system, having people who have had those experiences work with and talk to and engage with individuals who are going through that experience can be extremely helpful. During a time now across the nation where we have significant workforce issues, we haven't yet nationwide leveraged the utilization of peer supports in maintaining engagement, keeping connections with people who are going through, whether we're talking about a behavioral health crisis or walking through this behavioral health journey to recovery. So again, peer supports, whether you're talking about family support provider, youth peer supports, or recovery support specialists, whatever they are called in your state, they're the glue to holding the system together, and that's my belief.
Thank you for that. So Liz, you gave some examples of the use of peers. Can you and Shamika talk a little bit more about the role of peers in responding to calls? Are they going out alone? Are they going out with a clinician? What does that look like?
Well, that's a great question. It really is. And generally, let me just say this, in true mobile response and stabilization world, clinicians don't necessarily have to go. And I say that because in many states, certainly in New Jersey, and I imagine in Oklahoma, and a lot of the states that we talk with on a regular basis don't have enough clinicians to go around. Mm-hmm. So we use bachelor's prepared folks who are really well trained, certified, coached and trained to be the responders. And peer support partners go out together as a team, sort of in the same way that they do in the high fidelity wraparound world, where high fidelity wraparound facilitators always go with peer support partners, right? Because the way that we envision in systems of care is that parents are actually opening the door for us, right? They're making the door, they're helping parents be able to navigate and understand what it is that, that is available and can be helpful, right? So we want to think about it in the same line that peer support partners do. Go ahead, Shamika.
Yeah, Liz, we spoke about this the other day. I think that one of the great things about responding to youth in a crisis system is that 98.5% of the time there's going to be a caregiver, an adult present with the young person as a part of trying to maintain the stability of the crisis. And again, which makes the crisis situation, again, different. And so having individuals who are accustomed to working with families like care coordinators and family support providers or wraparound staff as a part of that front line, mm-hmm. again, puts pressure off the clinical workforce that requires licensed individuals and those individuals as a part of the response system. Again, and the training that they go through is extremely high quality training. And so really utilizing peer supports and care coordinators to do those de-escalation and diversion. And like here in the state of Oklahoma, our licensed individuals are there for kind of that crisis intervention, looking at that assessment and making determinations for us. And so licensed clinicians have to be a part of the team, but they don't necessarily have to be the first responders, in my opinion, in a children's system, because there's always an active adult present supporting that young person as a part of that crisis.
Right. So I see, Denise, that there's a question in the chat that's saying, wait, how do you do that without a clinician? And right. And the answer to that, let me just say right up front, is using a tool, an assessment tool that is not necessarily have to be completed by a clinician becomes mm-hmm. really important, right? So an assessment tool like the CAMS, the Child and Adolescent Needs and Strength, and the CAMS becomes really important because you can have your bachelor's prepared folks, your peer support partners, who can complete the assessment tools, review them with clinicians to ensure that they haven't missed anything, to make sure that individuals are getting what they need. Those things are allowable within the Medicaid world.
Right. And making sure that that licensed clinician is available. That clinician has to be available for consultation or support or assessment at any given time.
And while we're talking about that, we also want to make sure that there's a connection to psychiatric care, right? So we want to make sure that we can connect to a psychiatrist, to an adolescent psychiatrist, if that's what's necessary, right? What we would know is that it's just not necessary for every child, right? So assessment tools are going to help us figure out where we need to put a lot of time and attention and worry into places, and where other professionals can be helpful within these conversations. One other point about the peer support partner, right? The peer support partner really can be helpful in connecting the dots for what's necessary and what's helpful for families. And in some states, they actually use a very specific tool, not just the CAT, crisis assessment tool. With the families, they use the FANS, the family needs and strengths tool as well. So there's other companion tools to make sure that the family's concrete needs are met, and the social determinants of health.
Thank you. So I've just one more question before we move off peers. It's just been a great conversation. What about the use of peers at actual call centers? What are you seeing across the nation?
So we are not seeing a lot yet. We see a lot of folks who are very interested in trying to figure out how to make that happen. So I think that there's a lot of real interest in moving forward in the world of using peers at the call center level.
Right.
All right. But I think 988 has been part of this conversation, that we have to figure out how 988 is going to help us be able to achieve that as well.
Yeah. I think that's, that is really something to look at, Liz, because, our call center we don't have peers as a part of it. But as I mentioned earlier, during COVID, a lot of our calls that were coming in were parents that were anxious, concerned, and really needed someone to talk to themselves. So of course we were able to divert those calls to our statewide family network. But again, sometimes parents just need someone to talk to at that particular time.
That's right. And so I see that, so that Wendy from Georgia, of course, Georgia does have peer support. That's awesome and wonderful. And I forgot that Georgia was doing some pretty cool things in the call center. Wendy, I might have to talk to you later, by the way.
And Grace too. Grace is saying that Ohio's call center will use peers, and so does Colorado. Great. Thank you for saying.
Wow.
Krista would also, before we leave on peers, she would just also one more comment about a paired response. So are you seeing peers paired with a partner in responding?
Yeah, we're beginning to see that, right? We're beginning to see that folks are really moving in that direction. They are. In fact, it comes up a lot in the as we're planning and implementation with a lot of states. This is one of the core values that they want to bring to mobile.
Yeah.
Yeah. And again, a state the size of Oklahoma, where we're rural in proximity, we do have co-response peers and care coordinators. So
I'm going to move us to iPads, because the chat lit up, Shamika, while you were talking about the use of iPads. So Beth asked, in Kentucky, how do you cover the cost for iPads, et cetera, for families, as SAMHSA does not allow us to use their funds?
That is correct. So let me say this. What we have found in the state of Oklahoma, and again, kudos to our mental health providers here in the state, our community mental health centers and our CCBAC centers. So what we found here in the state of Oklahoma, the cost of the cost of utilizing an iPad into a home where you have a kid that has a high utilization of crisis services can be cost effective. And what I mean by that is, I guess most of states, again, when COVID came on, the expansion of Medicaid for technology utilization, some of our kids, again, need access multiple times within a 24-hour period. And that access point can be that iPad, that iPad connection to do that face-to-face, which also ties back to actual billable services. And so again, when you think about how much face-to-face time you can do with a person that is a high crisis utilizer, I think the cost of that iPad could definitely be I don't know what the word is. Effective. It can be an offset. Yep. Absolutely.
A few more follow-up questions on the use of iPads, Shamika. Does that assume that the family has access to internet or some sort of hotspot device is one question. And the other one is it's a comment and how do you get around this? So Beck says, I brought up the use of iPads with some groups of folks and they were like, oh, great. All the kids will be acting up and getting an iPad. Can you talk about how you address this dangerous mindset?
So just a little kind of over, just a review. So our iPads are definitely encrypted. And in addition to that, they're pretty much wiped clean. So the only things on our iPad is the location finder. So we can actually ping our iPads if they are on. And if they get lost, we can find them anywhere. In addition to that, there are specific apps that providers are utilizing to help with, de-escalating behaviors. There may be specific apps that allow a certain game, or it allows for kind of that wellness type of support that a young person needs. And then the only other option is to be able to connect to the treatment provider via iPad. So the iPad there's no other game availability or access to the internet that is allowed on those iPads. So they're really specific to work, assisting a kid that's in crisis, or assisting a kid that needs access to a licensed clinician.
Great. So I have one more. I know you're going to talk about collaboration, Liz.
Yes.
And Ellen Kagan, our friend Ellen, would love for you to talk about the importance of engaging, collaborating with law enforcement during that discussion.
Sure, absolutely.
So go back at it.
Yeah.
Go back to your slides and I'll keep tracking questions for folks.
Yeah, no problem. In fact, I was just going to talk about law enforcement real quick because, in the mobile response world, we're talking about, responders going out without mobile response, without law enforcement, right? So they're responding to all crisis situations without law enforcement being there and present, which I know for some folks might be a little new kind of idea. New Jersey has moved in that direction, has been there for well over 20 years. And I've said this before, I'm just going to say that, in my 5 years or over 5 years as assistant commissioner in New Jersey, where I was responsible for the full service array for IDD, for substance use, and for children with moderate and complex behavioral health needs, there was not one day that I worried about mobile response and stabilization not getting it right. They got it right 100% of the time that, that I was there. I worried about the higher intensities of service, right? I worried about young people in residential care. I worried about them in emergency departments and in inpatient care, and incidents occurring there took all of this time. And I say that because there was not one time where I thought, wow, law enforcement should be there. However, let me just say this, and I know Shamika is going to support this, in that the relationship with law enforcement has to be very tight. We have to train. We have to communicate. We have to talk on a local level on a regular basis in order for folks to get it right. Did you Shamika, I think you probably have.
Liz, you're absolutely spot on. I think that in any case where safety is not an issue, we want mental health professionals to respond. Okay?
That's right.
When safety is a factor, what we do here in the state of Oklahoma, we offer crisis intervention training to our law enforcement officers. In addition to that, the state has really worked with providers to equip law enforcement with iPads so that active duty law enforcement agents have a tool that they can utilize to get the people the help that they need. And that helps that, in our opinion, that help comes through an actual mental health professional. And in most cases, when safety is an issue, our law enforcement may respond first, and our mental health clinicians will come right in when it's safe. But there are some cases where we have to utilize that iPad technology to interface as a part of that. So yes, I think you're spot on.
Yeah, and I think the other part of this is that New Jersey's been at this for over 20 years. So they're pretty upstream, right? They've been doing this work for a long time. And even the age of engagement continues to lower. So we're talking, the age, we just even heard the updated data yesterday that, they've had an increase of connections with children under the age of 5.
Yes.
So So we're talking about, a very upstream way of viewing it. But at the same time, what we want to do is really try to figure out how we're going to partner with law enforcement in a way that that they're going to be true partners within this work. So that when they find children, as an example, or young people who they're worried about, they're helping parents connect, just as they are in Oklahoma with IPAC.
Correct.
So, okay, so let's talk about 988 real quick, right? And let's talk about the 988 implementation I know a lot of people a little worried about what's going to happen. I happen to be an optimist, so I think that the long-term view for 988 is very positive. The short-term just looks like it might have some bumps in the road. And so the way to think about 988, I think, is in terms of the infrastructure, the technology pieces. How do we customize specifically for children around the scripts that folks who answer the phone have, so that they know how to guide and direct the calls differently for individuals in particular under the age of 18. How do we have a really good script for 18, 19, 20, 25-year-olds who are calling and asking for assistance to get to in a way that makes sense? And then how do we shift away from the care pathways that take young people to emergency departments and inpatient care as the first step? So those are just some of the first thoughts. Shamika, I was curious what you're thinking about all that.
That is one of the biggest things that we're really trying to divert away from emergency room as a first point of contact. But it kind of goes back to what you said earlier. When families need help, they need help now. And so making sure that we create these care pathways that are interconnected through every aspects of our community is really important, whether we're talking about our schools or our clergy, faith-based community, but making sure the broader population across the state of Oklahoma and other states understand what this pathway needs to look like specific for access in 988, and making sure that through the 988 system, it is connecting to a system that is supportive of kids, utilizing some of the techniques that we talked about earlier, that same point of that, immediate point of contact. And that's kind of that single system of contact in order to facilitate these calls and facilitate with parents.
I think the power in 988, from my perspective, is that, one of the biggest challenges, I think, with having a single access number, New Jersey has used the same 1877 number for over 20 years, and yet still trying to get people to remember it, right? Remember when and how to call it. So the power of 988 is just really, from my perspective, so interesting. But at the same time, I think trying to get the infrastructure and the technology pieces to connect in a way that makes sense, and that those scripts, and making sure that there is customization. And I would argue not just customization for children, but customization for senior citizens and customization for veterans within that. Right. And then I think the next part about is the training of the workforce, and how do we get the workforce not only, to understand that 988 is coming, but how to be part of that work and understand what the role is, and the shifts that come with such a big transformation. Right.
Absolutely.
So, and then we have to engage our partners, and then, the creating of the feedback loops, which from my perspective, the feedback loops are the places in which we can get real information about the impact to young people and families, what their experience is, did it work the way that we thought it worked, and real-time ability to correct mistakes, to make sure young people get left hanging.
Absolutely, Liz, and that's really important because, just like I do, that, most of the world, when it comes to crisis, especially mental health crisis, when a kid says, I'm going to kill myself, or, talks about committing suicide, that is a major fear factor. And I think engaging partners and understanding that these mental health experts are available and can help the family to make decisions around whether we're talking about the least restrictive environment, whether we're talking about a path to treatment, whether we're really talking about what's best for them. And so I think that engaging partners is really around education and understanding of what can happen. Because I know early on with Oklahoma, when we first got into this, and the thought that a kid that said they were going to commit suicide was not going to go inpatient was like a fear factor for a lot of people. And so those partnerships are really going to be important. And then that feedback, you have to utilize that as an opportunity to define, refine, and make your system better. And so I think that those are really important points.
Exactly. This is how we all get better, right?
Yes.
So just quick, I just wanted to go through the mobile response continuum for folks so that those who are new to this idea or concept, you can see what we're talking about. So let me just walk you through the continuum. And what mobile response and stabilization is really, looks at this idea of intervening early in an upstream way that allows us not only to intervene right now, but also get to crisis prevention strategies. That there's a screening and assessment component, that there's home and community-based services that support the work of mobile response and stabilization, that we do safety planning, and that safety planning allows us to look at even like things like soothing tools for young people whose stress systems are really elevated. And by the way, soothing tools for parents whose stress systems are really elevated. That we think about planned respite and planned respite both formally in a formal system and informally by bringing and supporting other family members who could be part of these plans, right? We think about that single point of access and the triage, what the triage looks like in the children's world really is more about the idea of making sure that we understand the safety factors and that we're coming, right? You ask for help, we're coming. But we need to know really important things. And Shamika, I imagine you needed to know this, but when I worked in the rural parts of New Jersey, I wanted to make sure that I knew where to turn right when the GPS didn't work. Every once in a while I would hear, you got to turn at the cow, on this particular road. And so we want to make sure we know how to get there, what the house looks like, and we want to know who's going to be in the home, or are there weapons in the home, and are they secured, or are there dogs in the home, right?
Yes. And let me make one point on that. You just mentioned weapons in the home. A state like Oklahoma, we're rural in proximity. We have a lot of kids who hunt with their parents and have their own rifles and things like that. Right. And I think sometimes when you're looking at safety plan and the ability to maintain safe and keep kids in the community, again, our providers, gun locks. Yes. I mean, the number of kids that decreased after implementing gun locks was huge because, again, created a sense of safety and the kids didn't have the availability to get to their rifle or whatever the case may be.
That's right. Listen, I worked in the part of New Jersey where hunting is really big, right? And so we actually had to train both the responders and the care managers, right, who were doing high fidelity wraparound on how to actually have the conversations around guns, right?
Absolutely.
How do we help parents understand, what the roles of guns are? How do we help, really increase safety, which is really the goal, right? So really important part of knowing your community, knowing, having strategies to address some of the challenging areas around safety, not only for, in going into the home, but even some of the community safety factors that folks have to worry about. To give you an example, I worked in an urban center where we had to worry about some gang violence. And then when I worked in the rural community, we had to worry about the bears and we had to worry about, some of the animals that were of concern to the teams. So we have to think about the community safety component, which we can talk about. And we do have some time scheduled within one of the next learning communities to talk about that. So a couple other things just to hit on this, and we want to make sure that mobile response and stabilization is not only just connecting the dots in the short term, in the 72 hours and the 8 hours, which we're going to talk about in a second, but also that we are able to connect to the other parts of the continuum for children, because we don't want children to have to wait for things that we now know that they need. Okay, so let's, we're going to get to someone to respond next month. There we go. So this slide is really just about the interruption in the care pathway, right? Where do we get to intervene? And Shamika, maybe you could talk a little bit about some of the work that you do on helping young people, helping to interrupt some of the care pathways and take young people to emergency departments.
So, we've implemented what I would consider, intervention strategies as a part of our crisis system, where we're trying to intervene and strategize at a community level. And so whether it is our partnerships with our schools, really creating and identifying ways to maintain stability and calmness in the school environment, whether it is our mental health consultants who consult with early childhood providers and daycares, as well as Head Start programs. We also have most of our CCBACs have immediate access during the day, where a person can just walk in order to be seen by providers at that moment in time. And also,
Shamika, can you tell folks what a CCBHC is?
I'm sorry, CCBHCs is our certified community behavioral health providers. And that is a kind of a new thing, where we have a combination of overall wellness, physical health, as well as mental health as a part of an overall treatment aspect for individual. So I'm sorry, I keep throwing these acronyms out.
But just for that one person who might not.
Absolutely. And so I think that really looking at points of interruption is about partnerships within the community, whether we're talking about providing education, whether we're talking about programming, strategizing around strategizing with efforts where kids are involved. How do you work with your local civic group, Boys and Girls Clubs, YMCAs? What does that look like? But then also your school system, your formalized things like school system, childcare facilities, as well as your Head Start program. So creating those interruption points so that kids can get access before it becomes a crisis.
That's right. And people might be asking the question about daycare centers. And I just want to make this point, it's not uncommon for children to disrupt from daycare centers, right?
Yes.
So if we have the ability to actually stabilize within that daycare center, we can actually stabilize other parts of that child's life, right? So their housing, their parents' job, the, foster care situation. So we really want to be thoughtful about all of these interruption points. And places in which young people may disrupt, not only to end up in emergency departments, but in these disruptions are also problematic for them in other ways. So we want to be thoughtful about that. But the community engagement pieces are so incredibly important.
So Liz, before you go on, Deanna has a question for you about billing clients' insurance for this more preventative upstream approach. How do you do it? And do you want to talk a little bit about your experience in New Jersey and how it all worked out there?
Yeah, let me say that there's a couple of different strategies, right, for this. But in New Jersey, they took this really proactive public health approach. If we don't do this work, these young people are ending up in emergency departments. And I'm just going to say this right up front, that I worked in the system prior to mobile response and stabilization. And I spent more time than I can count in emergency departments with young people at all times of day, right? Because there were no other pathways, right? We had no other solutions for young people who were really struggling. And so there was recognition that the overuse and over-reliance on emergency departments, inpatient care, residential care, out-of-state residential care, and the state hospital were really problematic. And with that conversation, this public health approach of saying, we're going to pay for it, right? We're going to make sure that that public dollars are going to pay for the use of mobile response and stabilization has really led to the reduction. And I'll just give you, a couple of really important data points from New Jersey. One is there's no children in out-of-state residential care, right? The number of children, I would argue New Jersey has the best data around the use of residential care today, percentage-wise of all the children that they serve. They also have no state hospital. They closed the state hospital. They have reduced detention centers. They've closed 11 of them and closed the state prison. My point to you about all of this is that the reinvestment of those public dollars into providing mobile response and stabilization from this public health approach was really important. However, Massachusetts has said that we're going to work with the commercial insurance providers, and we're going to work with them to provide mobile response and stabilization work, right? Because we think it's a really important part of this work. So there are ways of looking at it, you know, to figure out whether or not you can connect with these commercial insurance plans. But Shamika, you're going to share some.
You know, Liz, I think that one of in the last slide, it says interruption points.
Yes.
And I'm glad it said interruption points, because oftentimes we speak of it as prevention, and it's really not a prevention.
That's
and so
right.
It's really about creating. I mean, sometimes the data will drive you to create something because, again, it starts being alarming. And so
That's
for
right.
us, it was really about looking at those points of interruption and really strategizing and planning programmatically around meeting the needs of those community partners, specifically in schools. You know, a lot of treatment providers provide treatment services as a part of school, but really creating a way of looking at specific data, real school partnerships, not just a means to go provide treatment partnerships. We have multi-MDT teams, multidisciplinary teams, and tiered approaches to how we do those types of interruptions. So I think, again, what I'm saying is programmatically planning and developing things that could work in some of these environments.
Absolutely. And just one other comment to that, and that is, you know, states have also used other public dollars, right? They use mental health block grant dollars as an example. They use, sometimes they use state general funds to pay for these for mobile response and stabilization, because the impact is so large around what happens in the other parts of your system. So there are lots of ways and strategies to get to how do you pay for this from a public health perspective. Our argument is that if you're not there, you know, can you take it just a little bit further? Can you cover more children than just Medicaid? Or can you cover some children with mental health block grant dollars? Can you cover them with other public resources as well?
Yeah.
So just some other thoughts. And we're happy to talk about that. We do have a financing you know, session coming up, in which we're going to think about all the ways that you can pay for mobile response and stabilization, and some of the other supports that are necessary to get that part right.
Absolutely.
Okay. So real quick, we just want to, you know, talk a little bit about the data. You know, we want to, from our perspective, it's really important to begin to collect data from the start. We want to figure out what data is necessary. We do have a data session. So for folks who are really interested in this topic, that will be coming up to learn more about how we make the decisions about what data collect, what would work for you, what would be the best data to think about. I'm going to move us quickly to the next slide, actually 2 slides down, because I know we're getting ready to run out of time. And I just want to talk quickly about some of the implementation strategies. So, and Shamika, I really want to have this conversation with you, because what's so impressive to me about what's going on in Oklahoma is how it started, right? So I was wondering if you might be willing in this slide just to tell a little bit about your peer story of the peer-to-peer work when you came for that ride along in New Jersey.
Well, you know, first, this as a state, we took different partner agency, child serving agencies, our Medicaid agency, our child welfare agency, juvenile justice, mental health, and others to the partnership meeting in Jersey. One of the things that was really huge and beneficial for us is to see it from a completely different lens, more of that response system types of lens, and to look at the nature of the types of calls that Jersey was responding to. It never fabric to us that this upstream intervention that we could do could actually be huge in preventing ongoing crisis. It can be huge in, you know, as an example, in the state of Oklahoma, we have an 80% plus diversion rate when we respond to kids in crisis in schools. And so that type of response has the ability to maintain kids in the classroom, in an environment, maybe go home for the day and able to return tomorrow. And so we never looked at it like this. So for us, the eye opener was not just creating a crisis system that saves lives, but
Mhm.
oh my God, we can change the trajectory of what happens with these kids. And so that was the eye opener for us.
Thank you, Shamika. Thank you for telling that. I appreciate it. Because, this is really complicated, hard work.
Mhm.
And it's really hard to understand. And it's hard to bring people along with you until they see it. And then when
Yeah.
you see it, you can't not see it that way, right? So
Absolutely.
listen, I know that we're getting ready to run out of time. So I'm just going to cover the two components of mobile response and stabilization for all of you. And then I think we'll be out of time. So let me just run them through real quick. There's a 72-hour component. That's the assessment part. That's the face-to-face with family. And there's this crisis de-escalation component that happens. And then there's up to 8 weeks of stabilization. What often comes up is, are they the same teams who do this work? Yes, generally in most states, they are the same team who does it. The 72-hour component of the work is really that face-to-face on the ground. 8 weeks of stabilization, there's a care coordination model that looks a little bit like high fidelity wraparound in that you're working to connect the dots to get that young person back into school, to make sure that they are engaged in activities, that there's community strategies in there. And we like to think about mobile response and stabilization as really a sequencing question, right? Is that young person ready for more formal supports? Because we don't force young people to get into these formal supports before they're ready. The evidence demonstrates that those outcomes aren't great. And for folks who are on this particular session, if you work with 18-year-olds who've had a bad experience, they'll tell you, I hate therapy, I'm never going back there. It's the worst experience of my life. Mobile response and stabilization is designed not to have that happen. And so, that 8 weeks of stabilization is really about engagement, connecting the dots, and making sure that we're bringing all the folks together who can be part of that team for that young person. Did you have anything to add, Shamika?
No, Liz, I don't think I have much to add. I think it's always a pleasure to talk to you about the importance of mobile response and stabilization and how impactful it has on the lives of children and families. And so I just, again, from me to you, I thank you for, talking today about this important effort and allowing me to be a part of it. So thank you.
Hey, Shamika, I didn't get through all the slides. It's very unusual for me. And that's because this has been such an engaging conversation about where you are and how far you've come in Oklahoma. And for me, I'm very excited about this work for all of you across the country who have joined us today. And I'm hoping you can join us for future discussions about how to bring mobile response and stabilization. Because my goal is mobile response and stabilization in every state in this country. So
Liz,
yes.
And Shamika, before you go, we did have one question from Beth Holloman, who said, how do you decide when to call in a qualified mental health professional? And I think it's really a great commercial, right, for next month's meeting on someone to respond. Do you want to talk a little bit about, give us a little preview about, get people to come back and join us again next month?
Yeah, absolutely. So I'm really happy to let folks know that we actually have a mobile response director who's going to join us for next month's session around what it looks like and when to respond to what it looks like actually in the home. And so she will walk you through when and how to use clinicians and the importance of clinicians in this conversation, but the importance of also using other members, other partners in the team to help. So yeah, it's next month. We're really looking forward to that.
Great. And so there may have been a few questions that we didn't get to. Gary, I'm going to ask you to save the chat and we can roll those questions into next month's discussion. And then Gary, I think it's time for you to close us out. Thank you.
All right, thank you for joining us for today's MRSS Learning Community session. A couple of things to note: don't forget to complete the evaluation survey that has been posted in the chat. It's also going to pop up once we end today's webinar. As a reminder, all of the presentations, certificates, recordings, and resources, as well as the links for future sessions, are housed in the MRSS Learning Community curriculum in the Ideas at the Institute Learning Management System. So make sure you pop in there in the next couple of days to download a PDF of today's presentation, as well as view the recording. And as mentioned, please join us next month for session 2, Someone to Respond To, on May 18th from 2 to 3:30 p.m. Eastern Time. And thank you for joining us today. Have a great day.